The periauricular percutaneous implantation of the neurostim system family of devices, the EAD, MFS, and Bridge, are cleared as minimal risk devices by multiple governmental and institutional facilities. This retrospective report of findings will help qualify the incidence of clinically observed bleeding, localized dermatitis, and infections at the implantation site of the electrode needle arrays, dermatitis at the site of the generator, and patient syncope. For this report of findings, the EAD, MFS, and Bridge, although packaged separately, are collectively referred to as the NSS, or Neurostim System. The NSS is a group of neurostimulation medical devices consisting of a battery-operated solid-state generator externally affixed by double-sided tape to the skin beside the ear, 4 wire connecting leads, and 4 attached electrode needle arrays, each consisting of 4 1.5 mm needles designed to be percutaneously implanted into the dermis of the external ear. The NSS devices are provided in disposable convenience kits consisting of a generator, sterile wire leads with arrays attached, transilluminator tweezers, surgical marking pen, several adhesives, bandages, disinfectant, and instructions for use. The devices and convenience kits are manufactured and assembled at Key Electronics in Jeffersonville, Indiana. All patients from the 6 participating centers who qualified within the accepted clinical guidelines for placement of the NSS were included in this study. Both male and female patients, aged 16 to 70 years, were included in the study. The use of transillumination to visualize, isolate, and target the auricular neurovascular bundles allows the clinician to avoid direct implantation into the vessels within the designated physiological zone. Upon percutaneous implantation of the arrays and the activation of the generator, a fractal geometric electronic field is produced which is designed to stimulate the targeted neurovascular bundles. 6 centers from a wide geographic and interdisciplinary background performed a retrospective chart audit for the preceding 12 months to ascertain the incidence of specified adverse reactions to placement of a total of 1,207 NSS devices. Each device has 4 electrode arrays consisting of up to 4 needles, which are percutaneously implanted into the dorsal or ventral aspect of the external ear, for a total of 16 percutaneous punctures per application. The result is a total cohort of up to 19,312 percutaneous punctures. Data from 4 different categories were collected: bleeding at any puncture site, dermatitis at a puncture site or at the generator attachment site, device pain precluding continued treatment, and syncope at time of implantation. Out of the approximately 19,312 punctures, 10 episodes of bleeding and 11 episodes of localized dermatitis were observed. No incidents of syncope, fainting, or infection were observed. As you can see, overall bleeding and dermatitis had the highest occurrences, with 0.057% and 0.062% respectively. The dorsal and ventral aspects of the auricle are heavily vascularized from branches of the superficial temporal artery and the posterior auricular artery. Cranial nerves 5, 7, 9, and 10, as well as branches of the greater and lesser occipital nerves, are also present in a predictable anatomical fashion. This allows the clinician to target specific cranial neurovascular bundles. The technique of transillumination avoids random placement, helping reduce the incidence of insertion directly into the peripheral arterial branches, greatly reducing the potential of bleeding. The use of FDA-cleared biocompatible materials and sterilization of the arrays and proper skin disinfecting technique, as outlined in the IFU, reduces the incidence of dermatitis and practically eliminates the chance of infection. There were no reported incidences of syncope in this cohort. However, due to the stimulation of the peripheral branches of the vagus nerve, possible vasovagal responses should be taken into consideration. Patients' pre-existing health conditions such as pregnancy, seizures, bleeding disorders, on-demand electrical implants, medications, and autonomic nervous system status must be taken into consideration. And while this report of findings supports a classification of minimal risk, it does not imply no risk. Risk assessment of patients on an individual basis must be determined by the clinician. Recommended placement technique including precise array implantation, proper implantation site disinfectant, careful monitoring of the patient's vital signs, and the availability of immediate supportive care is recommended. The FDA and IRB of the Defense and Veterans Center for Integrated Pain Management, or DVC-IPM, and the IRB at the Medical College of Wisconsin all categorize the use of the NSS as minimal risk. The low reported incidence of bleeding, dermatitis, infection, and syncope support these positions. However, the monitoring of the patient's vital signs and immediate availability of supportive care is always recommended.